Spend little time on the equipment. Can you hear me? Okay. See, the equipment, there is nothing great. The stores equipment which we are used to for a resection, same equipment. The only change here is if we are used to the bipolar this thing equipment, the same bipolar is here with a button electrode. This button is square size with the sharp edges. This button is known as Hermann button because Thomas Hermann was the one who designed this button electrode, and he is the one who was a part of Andreas Gross's team in Germany in early 2000, and the one who published papers on thulium-YAG laser enucleation of the prostate. When he started practicing independently, he saw that there is another energy which can be used for a enucleation of the prostate, and button he started using design is this Storz button. So this is known as a Hermann button, and instead of a loop, this button, we are all familiar with the button electrode because it is used basically for vaporizing the prostate in early 2000s, and it is used, some people use it for a coagulation at the end of the resection, coagulation of the fossa. The same button is designed with little bit sharp edges because it helps in cutting do a more or less precise cutting. It may or may not be as precise as a laser cut, but it does the job correctly, and I'll going to show you the same thing. In my practice, I use a Olympus button. I am not used to use this particular equipment, a button, but I have done few cases with the Storz button also, and I'll try to do justice like I do with the Olympus button with this particular equipment. So there is no other difference between Olympus and the Storz. As I told you earlier, this is the real bipolar electrocautery, and the Olympus is a quasi bipolar. So what we mean by a real and quasi bipolar? Quasi, the current jumps from the button to the sheath. Here there is another additional electrodes. So the jumping of current is a very short distance from here and does not have that longer path to go back to the electrocautery. That's the only difference. Otherwise the plasma, the effectivity is same for both the systems. So let us start the case. Any questions as far as the equipment is concerned? This is otherwise a standard Storz equipment. I have put in a continuation irrigation sheath. Outer sheath diameter is 26, inner sheath diameter is 24 French. Okay. Is that okay? Okay. I have studied before I went live on the air. I studied the morphology of the prostate, which is very important. I studied with the 17 French sheath and a simple cystoscopy. So it is very, very important as far as our Indian patients are concerned. You must evaluate the urethra before. Yeah, like yesterday we were discussing that the stricture urethra is one of the commonest consequence of a transurethral procedure, especially if it is going to last for a longer period. So urethra has to be capacious, and we must evaluate the urethra before we start any transurethral surgery. So that is why my routine, I calibrate the urethra with a 26 French dilator so that 26 French sheath goes in easily. For my holmium laser enucleation, these days I am used to a slim resectoscope or a slim system which has an outer diameter of a 22 French. So it solves our problem of handling the urethra a little bit. I will stop here when I will talk about it later. But right now we are dealing with a Storz system of a bipolar electrocautery with a button electrode, and my resectoscope easily went inside, and I will show you the morphology of the prostate. Any questions at this juncture?
What is the power setting?
Power setting, I will let the Storz people show you if they can. What is the power setting here? So every system has their own setting, but for a standard bipolar enucleation, you set how many, what is the range?
Sir, cutting is we have kept on 2 and population goes 3, the maximum goes up to 4, sir.
So 0 to 4 in both sides, the cutting they have kept it lower on the 2, and the coagulation setting is on the 3. This is news for me also. Can I thoda आगे ले लो? Like I told you earlier, I have studied the urethra, And can you see the button? Are you seeing the endoscopy picture? This is the bladder neck. Both ureteric orifice has been noted. And the best thing about the enucleation and avoid bladder neck, going very close to the ureteric orifice is to keep the bladder full so that the trigone stays away from the field of work. And this is prostatic urethra. The size must be approximately around 40 to 50 gram. That's it, my endoscopic evaluation. The lateral lobes are very prominent on the upper part, that is near the roof, that is near the anterior part of the capsule. So what I am going to do is, there is hardly any median lobe. So the technique wise, the holmium laser enucleation was demonstrated as a three lobe technique. What do we mean by three lobe technique? Is one, the incision of the prostate at 5 o'clock, another incision at 7 o'clock, so that you isolate the median lobe from the lateral lobe, and then there is a retrograde enucleation from Veru towards the bladder neck. So you remove the bladder median lobe first, and then you address the lateral lobes. That is known as a three lobe technique. Now see, what does laser do? Laser fiber is a end firing fiber. You can do enucleation of the prostate only with the end firing fiber. What do we mean by end firing fiber? The laser travels in a straight line and comes out at the tip and travels in the straight line. Vaporization of the prostate was done by a side firing fiber. Side firing fiber means the laser travels at right angle of the fiber. So it does a lateral, energy is delivered. So that is known as a side firing fiber. So with the vaporization, you scrub the prostatic surface like this, and the energy comes at 90 degrees, so it vaporizes the prostate. What does the bipolar do? I use this button as an end firing fiber of a laser. So this button is going to work like a laser fiber tip, and the energy is delivered to the prostate via this button. Now here, as there is hardly any median lobe, I am going to demonstrate a two lobe technique. What do we mean by a two lobe technique? We make a gutter, or the passage from bladder neck at 6 o'clock, right at the verumontanum on one side, like this. Now over a period of years, we realize that the capsule is very close to the lateral lobe or apex of the prostate. Here, if I incise this mucosa and go this, the capsule I'll find very close. So to define the capsule is easy at around the verumontanum, then at bladder neck. So we always start the case. These days I have been trying, starting with around the verumontanum first. So before I do, what I do, I mark my landmarks or distal limit. Yesterday we were talking about the incontinence. So incontinence can be preserved by preserving the mucosa around the verumontanum as much as we can. What do we mean by as much as we can? This is the verumontanum here. I want irrigation little up so that we get a clear field. 1 minute. While I talk, the bladder is full. So I'll empty the bladder. ये थोड़ा फॉगिंग हो रहा है. Okay. So I'll mark my distal limit. This is the verumontanum and sphincter is here. Sphincter is somewhere here. So you can always make out the apical part of the prostatic lobe. So what I'll do is that with the coagulation current, I'll mark my incision on the mucosa. So I'll preserve this much mucosa away from the sphincter. This is sphincter zone. This is verumontanum, and I'll mark my incision on the mucosa with the coagulation current like this. So this is my distal limit. I will not cross this limit as far as possible. And it is going to be an oblique incision. As I go anterior, I'll go inside. So my sphincter is oblique, my incision is also oblique. So when I go inside, I'll mark incision like this. I am using a coagulation current. So this marking is done on the right left lateral lobe, right on the lateral side and here, okay. Similar marking I will do on the right side, well inside the sphincter zone around the verumentinum with the coagulation current. And as I go anteriorly, I go little inside so that my marking is oblique and the mucosa spread is oblique around the sphincter zone. Now you know this is the marking done, and the most important marking is at 12 o'clock, which is slightly more inside. So this is my marking at 12 o'clock. You got my point? If you interact with me, I will know that you are listening to me. Hello. Can you see what my markings are?
Yes, yes.
Thank you very much. So once the marking is done, I have a choice. I can use this point from here to the bladder neck, which is not very long, to do the anterior commissurotomy. Or I have a choice of defining the capsule on the posterior side. So as I routinely do, I will define the posterior capsule first. Now I am going to use the cutting current. And in the spurts, small spurts, like this, you know, what I am doing, I am cutting the mucosa, small spurts, along the line of the markings. Can you appreciate this?
Yes, very nice.
So this is very important because I am cutting the mucosa only. I am not trying to get into the nodule or a prostatic adenoma. I am just cutting the mucosa. Short spurts of a cutting current, and I am going oblique as my marking. So मैं लक्ष्मण रेखा के बहुत अंदर हूँ, and with the short this thing I am cutting the mucosa. I am just, my aim is to cut the mucosa, not to do anything to the adenoma. So can you appreciate the cut made in the mucosa?
Yes.
So this is my step of cutting the mucosa all around the marking, well inside the sphincter zone with the sharp cutting electrode, cutting energy. Now when I go near to this thing mucosa, this is where my cutting of mucosa happens on the, to define the posterior capsule. Now what I'll do is, I'll here again cut the mucosa here. There will be some bleeding, you can coagulate with, so you stop the bleeding. Once you are done marking the, cutting the mucosa, you take it further deeper. So with little bit more energy, I am going to cut this in that line. Cut and coagulate so that your field remains clear. I want a little more. हाँ, ये कटिंग थोड़ा कम पड़ रहा है भैया, 3 कर दो. The trouble with the bipolar energy, it produces lot of air bubbles also. And one of the limitation of bipolar is that it creates air bubbles, so you have to manage that by stopping in between. ये irrigation बीच बीच में बंद हो रहा है. Once I incise for the adequate depth, I can use the mechanical force. I'll empty the bladder so that the pressure in the bladder remains low. So, any question in between you can ask. Yes, Amitabh.
Sir, previously when you were cutting, we were starting to cut from the bladder neck distally.
Right.
So, but now, once we reach up to the bone, we have a trunk. From there, once we start to get the posterior capsule, it will be easier for the beginners.
See, over a period of time you will learn something which is what is easier for you, and there is no harm in modifying technique, or the idea is to define the capsule properly. So here I am, because the cutting current is not to my satisfaction, it is taking little long time, but I am not in a hurry. I am just trying to define the place, a correct depth, and then I'll use the mechanical force to.
Sir, Mechanical pressure is by the scope or by the button?
By the button. See, mechanical is for the namesake mechanical, the movements are only gentle. And no force is used because the tissue should give way with a little force. If you apply a lot of force, then that it will not be. The idea is to make a incision wide enough to engage the beak of the resectoscope. Then it additionally helps in lifting the adenoma. Once you engage the beak like this and then try to move your scope, it helps in mechanical enucleation also. So the idea is to engage the beak of the resectoscope and use the current as and when required. Once the correct plane is there, you will see and appreciate the
How to identify the correct plane? Any tips and tricks?
you will see the capsule. See, the biggest tip is that you will see a crisscross blood vessels on the capsule. You should not go deeper than that. So you remain superficial to the blood vessels. See this is a small blood vessel I can see here.
Yes.
So this is how. See, bipolar, there is a difference. See, the difference is there between two energies. Bipolar is definitely little more crude. See this, I was telling you, blood vessel. So this is a blood vessel, so I will not go deeper than that. And
Sir, please show us one view of by keeping your scope on Veru. What has been done already?
pardon?
We want to see what has been done.
Okay.
from
See
Veru.
this. This is a Veru,
Yes.
and this is what we are trying to go on the left side, trying to define the capsule posteriorly on the left side.
Okay.
And I am using the sharp edge the button to cut the tissue.
So-
Cut the tissue and demarcate the plane.
First, the floor has to be.
Yes, the floor.
Cleared.
Yes, yes. Every prostate is different. Some, see, this prostate may be taking little longer time to peel off, or I may not be in the correct plane so far, but I feel that my plane is here only. This is the plane, because now it is going to it is getting easily peeled off like this.
Yes.
But again very close to the capsule. Why? Because the depth of the energy is not predictable. So you have to remain little outside, or superficial to a conceived depth capsule. See, I feel that the capsule is here and my working area will be little superficial to that. So I have defined the capsule here and here. And this is the plane I would like to remain. So I have defined the capsule on the left side of the verumontanum. Now I will define the in front of the verumontanum like this.
So you join the two incisions.
No,
The
the
lateral
second one I am yet to make, so I am just bridging this. See? Yeah, so the cleft is getting wider, I am going toward the center. So this is the correct plane here, and I am cutting the fibrous tissue which is connecting the adenoma and the capsule here. So in front of the verumontanum, from the left side to this way, now I will go here for a two-lobe technique from the bladder neck. This is about 5 o'clock incision. Somebody was saying resection with this. Yes, small tissue you can resect, but I am going to go to create a tunnel at between 5 and 6 o'clock from the bladder neck to here. So this is the tunnel I am making. and you are as close to the bladder floor. This is still some more. When in doubt, little bit undercutting is better than the overcutting. Once you go very close to the capsule with the bipolar energy, which is, it can violate the capsule. That's it. And the movement should be slower with the bipolar energy. Are you appreciating the tunnel being made from 6 o'clock to the Verumantenam? See, the idea of this demonstration is to be more confident with the energy you have. That's why I am going very slow. Plus, for me also, this equipment is slow, new. So, I am also very more watchful and careful. When you are demonstrating, safety is first. People talk about the overtime. See, everybody's overtime will be higher in their learning phase. Once you master the technique, then only you look at the time, what time you took to enucleate the prostate. Otherwise, take your own time, never be in a hurry, don't compromise at any level, and do the right job. That is more important. We are not using a sterile water or a glycine and running for the clock, but it is better to do a good job. So I am just trying. Now see, the crisscross vessel is a sign of here I am very close to the capsule. I won't go deep. So what my force will be little on the lateral side. Edge of the button I will use to separate the adenoma laterally now. Can you appreciate that? So I keep digging here, I will violate the capsule. So my job is done of defining the capsule at two places. Very important for the enucleation that you define your anatomical landmark. If you lose your plane, you come back to your defined landmark. So my landmark is defined here, here. I have gone to the capsule, closer to the capsule. I am going to avoid this area and go into a correct plane here, like this. Once I have done this, I will go to a 12 o'clock and do a anterior. See, this is what? The part of a nodule projecting here midway. But 6 o'clock is not that deep. So you have to understand that commissurotomy is not very deep. It is superficial. Capsule is very close. So I am doing a commissurotomy from bladder neck to this. I am doing one more channel or a burrow at the 12 o'clock. Remember, I have marked my distal limit at 12 o'clock. So I will keep looking at the Veru repeatedly. I will look at the Veru and turn my scope upside down and look at my distal limit. This is my distal limit. Very important to define this for preserving the incontinence. I am going deep at this place and then going inside. So that is proximal. I am going to vaporize this tissue at this level only and go inside like this. And I am not supposed to go deeper than this because not much of a tissue is there anteriorly. Capsule is very close.
For this you are using coagulating current?
No, I am using a cutting current. For marking the incision only and coagulating only for coagulation. Otherwise this is a cutting current. And to my experience, this cutting current is really very mild, not very strong. That's why I am taking little longer time. But now I have to define the capsule anteriorly from 12 o'clock to 2 o'clock like this. I am defining capsule here, see this? So I am not going to go deeper than this.
Yes.
I am working to widen the bladder neck. Can you appreciate?
Yes.
I am trying to cut the tissue with the side sharp edge of the button. So I have dropped my, it's like a Nesbit technique. From 12 o'clock near the bladder neck, the lateral lobe has been dropped like this. Now I have lifted the lateral lobe from here to here. Now lateral lobe is attached laterally like this. See this?
Yes.
Only this much attachment is here. Only this much. This much. See this?
Yes.
Can you appreciate this? Hello?
Sir, so
Yeah.
as the sir, so as the mark which you have made on the lateral.
Right. So I'll empty the bladder so that even with the continuous irrigation, bladder may not remain as empty as you would like to, because the rate of flow is always lower in the outgoing tube. Now can you appreciate this is a 12 o'clock incision?
Yes.
This is a part of the upper part of the left lobe which is dropped. This is the only this much mucosa is left to cut here. Now I am यहाँ मैंने mark किया था. I am
Yes.
going to remain well inside and incise the mucosa. So मैंने laterally भी mucosa cut कर दिया.
Okay.
Now I'll take deep here. For I am using cutting current. Yeah. Yeah, cutting is for vaporizing. Yeah, enucleation is basically you go between the adenoma and the capsule. What Dr. Madhu Agrawal does, we are missing him here. He starts at 12 o'clock, like this step he does, so that you gain a confidence. That is one known as vapoenucleation. You do it like a vaporization. At the same time, you are remaining closer to the capsule, so that you do a vaporization and enucleation. That is known as vapoenucleation. Once he drops the lobes like this, he resects because the lobes have become avascular. See, the beauty of enucleation is that you are not giving any chance for a bleeder which enters here. So, can you appreciate? Between 2 and 3 o'clock, the bleeders in the capsule will enter, but I am doing a vaporization, so unless I go deep and violate the capsule, it is not going to bleed. Can you appreciate? And when you come from lateral to the medial, you don't violate the trigon also. You never undermine the trigon because you have already defined your, see, this is how the capsule is defined on this side. Some prostatic tissue is there here, but I am not going to go deeper than this. Now I will come from below upward like this, my original plane here, this. And now a very little tissue is attached here, so I am going to remain inside this. And I feel, personally I feel this is the most difficult step. But you can make it easy by defining the capsule anteriorly and posteriorly. So very little tissue needs, if you do this without defining anterior and posterior capsule, it is the most difficult step.
Yes.
Yes. No difference, no difference. The bladder contracture is a sequelae of energy delivered to the tissue, and we are delivering thermal energy to the tissue, whether you do a enucleation or a resection, whether you do a laser or a TURP. So it is a consequence of a thermal injury. So I am going to remain close, superficial to this. I have gone very close to the capsule here, so I am going to avoid that area. This happens.
To me, the enucleation is most difficult between 2 and 5 o'clock.
Absolutely.
So is there any trick for that?
That is what I am saying, that you define your landmarks. See, my landmark was very well defined here at the floor. So I went closer to that and keep expanding that landmark. I am not closer to the capsule here. I am very closer to the capsule here. I will leave it that and come back to a normal plane. Now this laterally I have to go and meet at 12 o'clock here. So again you see, or you can come from here and cut this. I am cutting well inside the marked area and the sphincter zone. You got my point?
Yes.
Even if I leave behind a some nodule or part of the prostatic adenoma near a sensitive zone of a sphincter, it is fine. I can ablate it later if I find it significantly obstructing. But at least I am not violating the capsule. I am not violating the sphincter zone. I have remained inside the difficult area or a sensitive area. Can you see I have met my two incisions on either side. So I am going to define that and deeper and do a lateral enucleation like this. Can you appreciate? See, being able to appreciate what we speak is more important. If you do not understand, I'll explain it again.
So, so as the whole gland by keeping the scope on the veru,
Yeah.
where you have reached, let us see. This is, you are cutting at?
Cutting between 3 and 4 o'clock, laterally.
So whole gland is falling medially.
Yes. I am focusing only on the left lobe right now. I have not gone to the right side. Unless I finish my left lobe, I don't want to create more planes on the right side. So it is better to enucleate in. This is known as two lobe technique. So I did not go for the 3 lobe only because there was hardly any median lobe. Can you appreciate? I have done a lateral enucleation. There is a vessel here. I will coagulate that. Almost done. Do I need a laser? अपना टोयोटा से काम चलता है तो आपको BMW क्यों चाहिए? You can keep it attached here also, like Amitabh was telling, but now I believe that pure enucleation you should always adopt morcellation. So my left lobe is inside the bladder. Can you see this? The field is almost clear. Capsule is defined everywhere. Small blood vessels here.
Sir,
I'll just
your left lobe has fallen nicely into the bladder, but
Yes.
sometimes what happens, we are stuck in the roof. So what went wrong? If we
No,
are
no,
stuck
I
with-
defined my
I'm
roof.
not incised and
नहीं रूफ पे मैंने पहले ही कर दिया ना. See, I at 12 o'clock and this way I detached or removed the attachment of that left lateral lobe in the beginning only, and then left only for the lateral lobe attachment. Now I will focus on the right side. What I'll do is easiest part and safer part is to drop the.
So
I am going to widen the bladder neck on the right side. Yeah, between 10 and 11, I am at the bladder neck. So what I am doing is that defining the capsule or the circular fibers of the bladder neck here, like this. I am not doing it length. I am just widening the bladder neck so that a bigger adenoma falls easily. What I did that on the left side, I am doing it on the right side. So you don't have a difficulty in pushing the entire adenoma from the prostatic capsule. Can you see this?
Yes.
It is bladder neck is wide open on the right side also. So it helps me in defining the correct plane of enucleation laterally also. The wider you define the bladder neck is always better, so that your one correct anatomical landmark is very well defined.
So was the prostatic cavity from Veru, sir.
Yes, I'll show you. And there will always be a blood vessels near the bladder neck, you address them. Meticulously you coagulate. Now this is the
Veru.
Veru here.
Yes.
Now we have to do a job on this side also. मेरे marking तो इधर है, so I'll go deep here with a cutting current like this. Incise the mucosa only.
Okay.
I will go deep here. ये वाला marking है इधर. Incise the mucosa only, so that there is no stress to the lysosphincter. Lysosphincter is just inside the mucosa. So मैंने mucosa को release कर दिया ना, so I'll put less stress on the sphincter fibers. So as much as possible I'll release the mucosa on the sensitive part. Can you see the intact mucosa here?
Yes.
And this is lobe here. Now I can manipulate by going little deeper on this side without putting too much of a stress on the sphincter. So that preserves the continence. Because
We take the beak inside.
beak was initially needed, now entire scope goes. Now you see this mechanical. The spatula depends more on a mechanical, that's why I don't like it, or maybe I was not very successful in doing this. The only fellow on the earth is Mallikarjun, who does the best. Spatula. See this, now this is known as a mechanical enucleation. You should not do it unless you have an experience or a confidence. I am using a gentle force to create a right plane, but this prostate is not that suitable to do a good mechanical enucleation. So I will use the cautery current to separate the adenoma from the capsule and gently keep on pushing this like this. The best part of the mechanical enucleation gently done is that it takes you to the right plane. Cutting happens and it can cut anything which comes in between. So see this. अभी बीक से मैंने उसको उठाया है, तो जब विद gentle push and this crisscross vessel show me that this is a capsule. So with just current I will define that plane. Can you appreciate this mechanical thing? Now my priority is to finish the lateral lobe sensitive part, so I'll use a cutting. And another tip is that when in doubt, no, use a coagulation current, so it doesn't, does too much of a damage. When you are in doubt, use a coagulation current and mechanical enucleation, so that it doesn't damage the capsule. अभी मैंने फ्लोर डिफाइन कर दिया है, अभी मेरे को रूफ भी डिफाइन हो चुका है, तो this much attachment is there and this is my landmark, so I'll cut this mucosa here from above and go deeper than this in this area only. This is the difficult step, but you make it easy only by defining as much as anterior and posterior capsule. So I am trying to widen this gap.
In this area there is some adenoma.
Yeah, there is adenoma, so I am repeatedly looking at what is the correct plane. This is the correct plane. Tharman is a personal friend. He spent his endourology fellowship at Nadiad, so we have often interacted with each other in many workshops. And his design is, tapering. The tip, the base is wider, and so this helps you in pushing in a smaller place like this. Can you appreciate what I am saying?
Please repeat, sir.
Pardon? Yeah, the capsule, see, you always empty the bladder in between so that you know exactly the vision improves, because the flow of irrigation will reduce with the full bladder because of the intravesical pressure. And a small capacity bladder, if you are asking me that, it is difficult. You have to repeatedly empty the bladder. अभी ये वाला tissue I will leave very close to the capsule, so I won't attend. My larger interest is to enucleate laterally and do my job in a correct plane. The limit is only in your experience. So if you are confident and experienced, you can do up to 100-150 gram. The largest bipolar enucleation I have done is a 200 grams. So if you are confident about the steps of enucleation, you can do any size, because enucleation is meant for a large size, and a small size nothing significantly changes. Yeah. Enucleation is good for big prostate. Enucleation is there for every prostate. Even you give me a 20 gram prostate, I will enucleate that small nodule. That is not an issue. But does it have an advantage? No, because 20 gram prostate you will resect in 20 minutes. I will enucleate in 10 minutes. Does it make any difference? No. But to learn to do a good 60 gram prostate, you may have to go do 10-30 gram prostates. No, it's a myth. It's a myth. The principle of finding a correct plane remains same in a larger. And larger prostate adenoma weight also does a good job. See, ये वाला adenoma गिरता जा रहा है तो मेरा traction automatically बनता जा रहा है. Can you appreciate that? ये वाला adenoma गिर रहा है इधर, तो ये traction तो आ ही गया. Yeah. No, it is difficult for sure. See, even the resection for a smaller prostate is difficult because you reach the capsule faster. So you must know the limit, capsular limit, whether it is resection or enucleation.
That is why for smaller prostate we recommend QIP.
Oh, good. That is what I agree 100%. That TUIP, see, if it is relieving the obstruction, any procedure is good. If TUIP is doing a good job, why do you want to resect? If TURP is doing a good job, why you want to do enucleation? But if you look the why enucleation has to be done, because you have to have a good perioperative recovery and morbidity, and long-term functional outcome is better. People have seen, you know, the literature, what does the literature say? A very well done TURP has a reoperation rate of 4% at the end of 1 year. What do you mean by 4%? Is that you leave behind the residual adenoma. Very well done TURP,
We
I am
would
saying.
like to see the prostate from Veru, sir.
I'll show you everything. See,
Very
see, some tissue I said that I am going to leave to address it later to avoid complication is this one. Now this is a verumontanum here,
Yes, yes.
and this is
Attachment.
attachment.
Residual attachment.
ये वाला फ्लोर वाला आ गया वापिस. ये वाला फ्लोर आ गया. अभी मेरा ब्लैडर नेक सब तरह से डिफाइन है, तो आई एम नॉट गोइंग टू अंडरमाइन द ट्राइगोन. आई नो वेयर एग्जैक्टली द प्लेन इज लीडिंग मी. See, that is what I told you earlier, defining the bladder neck as much as you can, it helps you. Can you appreciate? The right lobe enucleation is almost done.
Yes.
Can you appreciate the side of the button cutting nicely? Done. So this is verumontanum. This is tissue which is in the near the sphincter zone. A small adenoma or a part of adenoma left behind, you can vaporize this like this. You see, very safe, very safe. instead of struggling to enucleate this part, you just vaporize. You don't need to vaporize also because it is very small thin layer of the adenoma. Can you see this? Anteriorly nicely separated from all around, wide prostatic fossa and landmarks preserved very well inside the sphincter zone. Okay? So 2 lobes of the prostate enucleated, floating freely, good hemostasis. Even at the, if I always empty the bladder and see the level of hemostasis. The return is almost clear if you see the surface.
Yes.
So the bipolar enucleation is as good as a laser enucleation, provided you know the technique. Do you agree?
Yes.
Wrong in leaving the patient and bladder neck. If you have a oscillator,
Professor Manson was saying that in the size of the prostate, in the smaller prostate, we do not encounter with chronic prostatitis features. In that scenario, it's very difficult to find the plane and stay in the plane. So for the smaller prostate, sometimes it becomes difficult with the bipolar enucleation.
See, I don't want to discuss further for the enucleation for a smaller prostate. You have a choice. You are not doing anything wrong by doing a good resection or going to TUIP. If somebody is not convinced to do a enucleation for a smaller prostate, I don't mind it. Yes, because the functional outcome is and the perioperative recovery is as good as with any enucleation procedure. See, here also I was very close to the capsule. I realized very early in my enucleation.
Some undermining is there. No?
Yeah. So because
And what
see
you will do the residual prostate on the right side near apex?
ये इसको vaporize करेंगे ये ला. I'll try to find a plane here
Yes.
by doing this. Pardon? It's almost wide. See, bladder neck is wide open. Why do I need a BNI? It is not going to trouble me. You don't need to go outside the bladder and complete this BNI always. Because people used to believe that bladder neck stenosis happens, but that is in a smaller prostate where the bladder neck is narrow. Or here this wide bladder neck, it may going to contract, but stenosis is different. I don't need to do. See this, I have enucleated that small adenoma,
Yes.
part of the adenoma.
Yes.
just asking a question, it might be silly. You have used any other instrument, Wolf for bipolar enucleation? Wolf ever you have used or only?
Wolf doesn't have a bipolar.
Yes, sir, they have.
Then I have not used it. See, the bipolar technique, the Olympus has, it doesn't connect well with the Shawley equipment also. So they have a difference. So that is what the industry does. Only I can't connect my bipolar to a Shawley bipolar equipment. It doesn't work.
Sir, are there any consequences of a small capsular population like we have in this?
This is okay, fine. As long as you have noticed and there is no sinus, this thing, it is okay. Are you happy with the hemostasis?
Yes. Yes.
You have to make sure that everything is controlled
do-
before you start the morcellation.
Do we need to do so much of hemostasis?
Yes, for a morcellation you need a, see the best part of morcellation is that clear, nice, view is more important. If you are not seeing anything, don't morcellate because you will never know what you morcellate. So the trick of the morcellation is perfect hemostasis. ये वाला थोड़ा इधर tissue है, I can dig it out and then do a vapo-enucleation kind of a thing.
What you are telling that this will not happen with HOLEP.
Yeah, this will not happen. No, you can purposefully leave behind this for the safety. And then you tackle it later with the HOLEP also. Something which is very attached, I don't think that it is too much of a significance. I'll just vaporize it.
What was the problem? You were worried about the incontinence or the perforation?
Perforation. See, losing, getting back to this thing, incontinence happens only if I do some galata here, near the sphincter. If I stretch it further in this region, incontinence will happen. If I stretch it here further at 12 o'clock here, incontinence will happen. Not with this.
That's why you are taking the incision bit anterior.
See, the urine is clear. I am ready for the morcellation.
So-
Morcelloscope कौन सा है?
So your message is that if
इसी
you
में?
doubt, leave the obstruction,
Yeah.
you can take care of obstruction later on,
Yes.
but never over resect.
Yes, exactly. You got the point. That when in doubt, do under enucleation. इससे तो जाना नहीं चाहिए लेकिन मैं गया. ओके ये वाला भी निकाल देना पड़ेगा मुझे सर।
सर
रहेगा?
उधर स्कैनर दिलवाए?
क्या? हाँ दिला दो दिला दो। हाँ हाँ
नेक्स्ट OT स्पाइरल
ये लो, आराम पकड़ा। सरफेस कैमरा दिख रहा है क्या? हेलो, आई एम विथ यू।
हेलो हेलो महेंद्र सर
हाँ हाँ, see the morcelloscope is here, this is the telescope with the bridge and the outer sheath remains the same, so you don't take out the entire assembly, and I have switched off the outlet, so I am filling up the bladder. What I need is a full bladder for the morcellation. लगा दीजिए। हाँ, because charring is less with the, it is there, but compared to thulium, it is less.
पानी थोड़ा तेज कर दो।
ये देख रहे हैं क्या? So hemostasis is good, my vision is clear, and this is a Storz morcelloscope, morcellator.
पानी तेज कर दो।
मोर्सेलेटर में क्या है, सक्शन और दो स्विच होती है। इफ आई प्रेस लाइटली इट विल सक। कैन यू सी द ब्लड मोर्सेलेटर ब्लेड कमिंग अप? दिस इज द ब्लेड। नाउ प्रेस करेंगे तो हाँ, और डीप प्रेस करेंगे तो मोर्सेलेशन ऑन। और you should always see what is being morcellated. So your focus or concentration is on the tip of the morcellator blade. What is being morcellated is to be observed. You will not know irrigation कम हो गया तो bladder का suction हो जाता है तो bladder wall comes very close. So that is the only complication you must avoid. That you should be always observant of what is being morcellated. थोड़ा स्पीड बढ़ा सकते हैं क्या ब्लेड का? मैक्सिमम क्या है? तो 3000 करो। ठीक है, मेरे लिए भी नया है, 2000 करो। Yeah, higher is not always better. Can you appreciate the speed of the morcellation? If you put it higher, no, the suction also has to be faster. क्योंकि वो ब्लेड के मूवमेंट से एडिनोमा दूर चला जाता है, सक्शन से ये नज़दीक आता है, और if you keep it faster, it will go away and it will not get morcellated. So there has to be a balance between the irrigation. I have a double irrigation in my press. Here only single irrigation is done. But the speed of the morcellator blade is at the medium level. 1500 है ना? एक लोब तो morcellate हो गया, दूसरा करेंगे हम।
इरिगेशन में इनलेट तो एक ही है सर।
नहीं, ये दूसरा इधर से है ना, ये वाला लगा सकते हैं, ये आउटलेट वाले से हम लगा सकते हैं। ये क्यों सक्शन नहीं हो रहा है? सक्शन बढ़ाना पड़ेगा। हाँ, वो सक्शन का बॉटल भर गया होगा इसीलिए। See, for morcellation you need a floor team which is very efficient. They should be able, your focus is only on the morcelloscope blade. The rest of the things are seen by your team. So the nursing staff and the floor team has to be trained properly to handle the morcelloscope equipment. I am not very well trained because I always look at the adenoma and the morcelloscope blades. But my staff is very well trained. They know what are the issues. Very important to reduce the morcellation time. ब्लेड चल रहा है कि नहीं, सक्शन चल रहा है कि नहीं. That is why mechanical failure में the morcelloscope failure was as high as 58%. Yesterday somebody presented. Absolutely correct. So morcellation needs lot of coordination in your OT staff. Can you appreciate morcellation? You should be just inside the bladder neck and always mindful of bladder fullness and the vision. We are not in a hurry. देखो ये अभी एयर बबल आ गया तो इरिगेशन कम हो गया है, थोड़ा और बढ़ाओ सारा, नहीं तो फिर मैं ब्लैडर फुल होने दूंगा. आई डोंट वांट माय ब्लैडर टू बी एम्प्टी. जरूर होगा तो मैं दूसरा इरिगेशन लगाऊंगा. या बट ब्लैडर इज फिलिंग अप नाइसली.
Has it happened that you have left the morcellation for after 2 days ever?
Yes, yes. For a bigger prostate, I have done several times, maybe 4 or 5 times. The morcellation after 48 hours becomes a very easy job. Suction नहीं चल रहा है भैया. You tell me when the suction is ready. Ready?
So for a bigger gland, why you restage it? Because of time issue or there is bleeding?
Yeah, time issue and some morcellus vision is not clear. You are not confident to go ahead. Safer to stage it. You don't need a suprapubic cystotomy to be done.
Have you ever used Mormeyer's punch?
No. I have used PCN laparoscopy forceps to grasp. These are known as beach balls. You see this?
Yes, sir.
Nodules. They are notorious.
Sir, there are two questions from the audience. Hello?
Hello? Yes.
Two questions from the audience. How do we collect the specimen for histopathology after morcellation?
The audio is not so good. I can't understand
The
the question.
question is that how you collect the specimen for histopathology?
और ये वाला सक्शन के बॉटल में सब छुंदा होके गया है. Small, small, shreds of the prostatic tissue is there in the suction bottle. So you can send it for the histopathology.
Second question, sir. If we are going for the large gland, and you are taking the back up to back, can we go for a morcellation for 48 to 24 hours?
Yes, 48 hours, the bigger, avascular lobes becomes very soft and easy to morcellate. Morcellation का स्पीड कम करो, 1000 कर दो. और give me a grasper. हाँ.
Sir, occasionally this happens. Ping pong होता है.
Okay. Small spots of morcellation. I am pressing the foot switch repeatedly so that it doesn't run away. Yeah. Problem is that suction remains open. Good. Done? Can you see? I have just finished.
So half is for suction and then full is for morcellation.
Yes. So there is no more chunk of tissue remain in the.
And again you will do the incision.
If needed, these are all oozing and there is no arterial bleed. I will go in and coagulate. There is no arterial bleed. This is just because the prostatic fossa is empty.
This much of oozing is also there in HOLEP or only in bipolar reversing?
Everywhere. The
HOLEP is
fossa is fossa. It will ooze. Even the whole lip also same. Hello. Yes. I follow all the steps of TURP. In my private practice, I don't want to attend to them in post-operative period, but traction is not mandatory. Traction is for 4-5 hours. Catheter 48 hours. 35 ml फुला के ट्रैक्शन दे दो.
Yes, now you can come.
Okay. So bipolar enucleation. Enucleation is enucleation, whether it is bipolar or a HOLEP.